Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Subcutaneous administration of a monoclonal antibody to prevent malaria. Background. Subcutaneous administration of the monoclonal antibody L9-LS protected adults against controlled Plasmodium falciparum infection in a Phase 1 trial. Whether a monoclonal antibody administered subcutaneously can protect children from P. falciparum infection in a region where this organism is endemic is unclear. Methods. We conducted a Phase 2 trial in Mali to assess the safety and efficacy of subcutaneous administration of L9-LS in children 6 to 10 years of age over a 6-month malaria season. In Part A of the trial, safety was assessed at 3 dose levels in adults, followed by assessment at 2 dose levels in children. In Part B of the trial, children were randomly assigned, in a 1:1:1 ratio, to receive 150 mg of L9-LS, 300 mg of L9-LS, or placebo. The primary efficacy endpoint, assessed in a time-to-event analysis, was the first P. falciparum infection, as detected on blood smear performed at least every 2 weeks for 24 weeks. A secondary efficacy endpoint was the first episode of clinical malaria, as assessed in a time-to-event analysis. Results. No safety concerns were identified in the dose escalation part of the trial, Part A. In Part B, 225 children underwent randomization, with 75 children assigned to each group. No safety concerns were identified in Part B. P. falciparum infection occurred in 36 participants, 48%, in the 150 mg group and 40% in the 300 mg group and in 81% in the placebo group. The efficacy of L9-LS against P. falciparum infection, as compared with placebo, was 66%, adjusted confidence interval, 95% C, 45 to 79, with a 150 mg dose and 70%, adjusted 95% C, 50 to 82, with a 300 mg dose, P less than 0.001 for both comparisons. Efficacy against clinical malaria was 67%, adjusted 95% C, 39 to 82, with a 150 mg dose and 77%, adjusted 95% C, 55 to 89, with a 300 mg dose, P less than 0.001 for both comparisons. Conclusions. Subcutaneous administration of L9-LS to children was protective against P. falciparum infection and clinical malaria over a period of 6 months. Apolipoprotein A1 infusions and cardiovascular outcomes after acute myocardial infarction. Background. Cardiovascular events frequently recur after acute myocardial infarction, and low cholesterol efflux, a process mediated by apolipoprotein A1, which is the main protein in high-density lipoprotein, has been associated with an increased risk of cardiovascular events. CSL112 is human apolipoprotein A1 derived from plasma that increases cholesterol efflux capacity. Whether infusions of CSL112 can reduce the risk of recurrent cardiovascular events after acute myocardial infarction is unclear. Methods. We conducted an international, double-blind, placebo-controlled trial involving patients with acute myocardial infarction, multivessel coronary artery disease, and additional cardiovascular risk factors. Patients were randomly assigned to receive either 4 weekly infusions of 6 grams of CSL112 or matching placebo, with the first infusion administered within 5 days after the first medical contact for the acute myocardial infarction. The primary endpoint was a composite of myocardial infarction, stroke, or death from cardiovascular causes from randomization through 90 days of follow-up. Results. A total of 18,219 patients were included in the trial, 9,112 in the CSL-112 group and 9,107 in the placebo group. There was no significant difference between the groups and the risk of a primary endpoint event at 90 days of follow-up, 439 patients, 4.8%, in the CSL-112 group versus 472 patients, 5.2%, in the placebo group. Hazard ratio, 0.93, 95% confidence interval, C, 0.81 to 1.05, p equals 0.24, at 180 days of follow-up, 622 patients, 6.9%, versus 683 patients, 7.6%, hazard ratio, 0.91, 95% C, 0.81 to 1.01, or at 365 days of follow-up, 885 patients, 9.8%, versus 944 patients, 10.5%, hazard ratio, 0.93, 95% C, 0.85 to 1.02. The percentage of patients with adverse events was similar in the two groups. A higher number of hypersensitivity events was reported in the CSL-112 group. Conclusions. Among patients with acute myocardial infarction, multivessel coronary artery disease, and additional cardiovascular risk factors, 4 weekly infusions of CSL-112 did not result in a lower risk of myocardial infarction, stroke, or death from cardiovascular causes than placebo through 90 days. Transcatheter or surgical treatment of aortic valve stenosis. Background. Among low-risk patients with severe, symptomatic aortic stenosis who are eligible for both transcatheter aortic valve implantation, TAVI, and surgical aortic valve replacement, SAVR, data are lacking on the appropriate treatment strategy in routine clinical practice. Methods. In this randomized non-inferiority trial conducted at 38 sites in Germany, we assigned patients with severe aortic stenosis who were at low or intermediate surgical risk to undergo either TAVI or SAVR. Percutaneous and surgical valve prostheses were selected according to operator discretion. The primary outcome was a composite of death from any cause or fatal or non-fatal stroke at 1 year. Results. A total of 1,414 patients underwent randomization, 701 to the TAVI group and 713 to the SAVR group. The mean, plus or minus, age of the patients was 74 plus or minus 4 years. 57% were men, and the median Society of Thoracic Surgeons risk score was 1.8%, low surgical risk. The Kaplan-Meier estimate of the primary outcome at 1 year was 5.4% in the TAVI group and 10.0% in the SAVR group. Hazard ratio for death or stroke, 0.53, 95% confidence interval, C, 0.35 to 0.79, p less than 0.001 for non-inferiority. The incidence of death from any cause was 2.6% in the TAVI group and 6.2% in the SAVR group. Hazard ratio, 0.43, 95% C, 0.24 to 0.73. The incidence of stroke was 2.9% and 4.7%, respectively. Hazard ratio, 0.61, 95% C, 0.35 to 1.06. Procedural complications occurred in 1.5%, and 1.0% of patients in the TAVI and SAVR groups, respectively. Conclusions. Among patients with severe aortic stenosis at low or intermediate surgical risk, TAVI was non-inferior to SAVR with respect to death from any cause or stroke at 1 year. Recombinant Adams 13 in congenital thrombotic thrombocytopenic purpura. Background. Congenital thrombotic thrombocytopenic purpura, TTP, results from severe hereditary deficiency of Adams 13. The efficacy and safety of recombinant Adams 13 and standard therapy, plasma-derived products, administered as routine prophylaxis or on-demand treatment in patients with congenital TTP is not known. Methods. In this Phase 3, open-label, crossover trial, we randomly assigned patients in a 1-to-1 ratio to 2 6-month periods of prophylaxis with recombinant Adams 13, 40 IU per kilogram of body weight, administered intravenously, or standard therapy, followed by the alternate treatment. Thereafter, all the patients received recombinant Adams 13 for an additional 6 months. The trigger for this interim analysis was trial completion by at least 30 patients. The primary outcome was acute TTP events. Manifestations of TTP, safety, and pharmacokinetics were assessed. Patients who had an acute TTP event could receive on-demand treatment. Results: a total of 48 patients underwent randomization, 32 completed the trial. No acute TTP event occurred during prophylaxis with recombinant ADAMTS13, whereas one patient had an acute TTP event during prophylaxis with standard therapy, mean annualized event rate, 0.05. Thrombocytopenia was the most frequent TTP manifestation, annualized event rate, 0.74 with recombinant ADAMTS13 and 1.73 with standard therapy. Adverse events occurred in 71% of the patients with recombinant ADAMTS13 and in 84% with standard therapy. Adverse events that were considered by investigators to be related to the trial drug occurred in 9% of the patients with recombinant ADAMTS13 and in 48% with standard therapy. Trial drug interruption or discontinuation due to adverse events occurred in no patients with recombinant ADAMTS13 and in 8 patients with standard therapy. No neutralizing antibodies developed during recombinant ADAMTS13 treatment. The mean maximum ADAMTS13 activity after recombinant ADAMTS13 treatment was 101%, as compared with 19% after standard therapy. Conclusions: during prophylaxis with recombinant ADAMTS13 in patients with congenital TTP, ADAMTS13 activity reached approximately 100% of normal levels, adverse events were generally mild or moderate in severity, and TTP events and manifestations were rare. Next, we will be discussing articles from Journal of American Medical Association. Racial and ethnic disparities in all-cause and cause-specific mortality among U.S. youth. Importance: mortality rates in U.S. youth have increased in recent years. An understanding of the role of racial and ethnic disparities in these increases is lacking. Objective to compare all-cause and cause-specific mortality trends and rates among youth with Hispanic ethnicity and non-Hispanic American Indian or Alaska Native, Asian or Pacific Islander, Black and white race. Main outcomes and measures: pooled, all-cause and cause-specific mortality rates per 100,000 youth, hereinafter, per 100,000, for leading underlying causes of death were compared. Injuries were classified by mechanism and intent. Results: between 1999 and 2020, there were 491,680 deaths among U.S. youth, including 8,894, 1.8%, American Indian or Alaska Native, 14,507, 3.0%, Asian or Pacific Islander, 110,154, 22.4%, Black, 89,251, 18.2%, Hispanic, and 267,452, 54.4%, white youth. Between 2016 and 2020, pooled all-cause mortality rates were 48.79 per 100,000, 95% C, 46.58 to 51.00, in American Indian or Alaska Native youth, 15.25 per 100,000, 95% C, 14.75 to 15.76, in Asian or Pacific Islander youth, 42.33 per 100,000, 95% C, 41.81 to 42.86, in Black youth, 21.48 per 100,000, 95% C, 21.19 to 21.77, in Hispanic youth, and 24.07 per 100,000, 95% C, 23.86 to 24.28, in white youth. All-cause mortality ratios compared with white youth were 2.03, 95% C, 1.93 to 2.12, among American Indian or Alaska Native youth, 0.63, 95% C, 0.61 to 0.66, among Asian or Pacific Islander youth, 1.76, 95% C, 1.73 to 1.79, among Black youth, and 0.89, 95% C, 0.88 to 0.91, among Hispanic youth. From 2016 to 2020, the homicide rate in Black youth was 12.81, 95% C, 12.52 to 13.10, per 100,000, which was 10.20, 95% C, 9.75 to 10.66 times that of white youth. The suicide rate for American Indian or Alaska Native youth was 11.37, 95% C, 10.30 to 12.43, per 100,000, which was 2.60, 95% C, 2.35 to 2.86 times that of white youth. The firearm mortality rate for black youth was 12.88, 95% C, 12.59 to 13.17, per 100,000, which was 4.14, 95% C, 4.00 to 4.28 times that of white youth. American Indian or Alaska Native youth had a firearm mortality rate of 6.67, 95% C, 5.85 to 7.49, per 100,000, which was 2.14, 95% C, 1.88 2.43 times that of white youth. Black youth had an asthma mortality rate of 1.10, 95% C, 1.01 to 1.18, per 100,000, which was 7.80, 95% C, 6.78 to 8.99 times that of white youth. Conclusions and relevance in this study: racial and ethnic disparities were observed for almost all leading causes of injury and disease that were associated with recent increases in youth mortality rates. Addressing the increasing disparities affecting American Indian or Alaska Native and Black youth will require efforts to prevent homicide and suicide, especially those events involving firearms. Youth experiencing parental death due to drug poisoning and firearm violence in the U.S., 1999 to 2020. Importance: youth, those aged less than 18 years, parental death has been associated with negative health outcomes. Understanding the burden of parental death due to drug poisoning, herein, drugs, and firearms is essential for informing interventions. Objective: to estimate the incidence of youth parental death due to drugs, firearms, and all other causes. Design, setting, and participants. This cross-sectional observational study was conducted using vital registration, including all U.S. decedents, and census data from January 1990 through December 2020. Data were analyzed from May 30, 2023, to March 28, 2024. Exposures: parental death due to drug poisoning or firearms. Main outcomes and measures: a demographic matrix projection model was used to estimate the number and incidence of youth experiencing parental death, defined as the death of one or more parents, per 1,000 population aged less than 18 years. Analyzes evaluated parental deaths by drugs, firearms, and all other causes from 1999 through 2020 by race and ethnicity. Results: between 1999 and 2020, there were 931,785 drug poisoning deaths and 736,779 firearm-related deaths with a mean SD age of 42.6, 16.3 years. Most deaths occurred among males, 73.8%, and white decedents, 70.8%, followed by Black, 17.5%, and Hispanic, 9.5%, decedents. An estimated 759,000, 95% C, 722,000 to 800,000 youth experienced parental death due to drugs, and an estimated 434,000, 95% C, 409,000 to 460,000 youth experienced parental death due to firearms, accounting for 17% of all parental deaths. From 1999 to 2020, the estimated number of youth who experienced parental death increased 345%, 95% C, 334% to 361%, due to drugs, and 39%, 95% C, 37% to 41%, due to firearms, compared with 24%, 95% C, 23% to 25%, due to all other causes. Black youth experienced a disproportionate burden of parental deaths, based primarily on firearm deaths among fathers. In 2020, drugs and firearms accounted for 23% of all parental deaths, double the proportion in 1999, 12%. Conclusions and relevance: results of this modeling study suggest that U.S. youth are at high and increasing risk of experiencing parental death by drugs or firearms. Efforts to stem this problem should prioritize averting drug overdoses and firearm violence, especially among structurally marginalized groups. Next, we will be discussing articles from Annals of Internal Medicine. Deep Learning to Estimate Cardiovascular Risk from Chest Radiographs, a Risk Prediction Study. Background. Guidelines for Primary Prevention of Atherosclerotic Cardiovascular Disease, ASCADE, recommend a risk calculator, ASCADE risk score, to estimate 10-year risk for major adverse cardiovascular events, MACE. Because the necessary inputs are often missing, complementary approaches for opportunistic risk assessment are desirable. Objective: to develop and test a deep learning model, CXR-CVD risk, that estimates 10-year risk for MACE from a routine chest radiograph, CXR, and compare its performance with that of the traditional ASCADE risk score for implications for statin eligibility. Design: Risk Prediction Study. Setting: outpatients potentially eligible for primary cardiovascular prevention. Participants: the CXR-CVD risk model was developed using data from a cancer screening trial. It was externally validated in 8,869 outpatients with unknown ASCADE risk because of missing inputs to calculate the ASCADE risk score, and in 2,132 outpatients with known risk whose ASCADE risk score could be calculated. Measurements: 10-year MACE predicted by CXR-CVD risk versus the ASCADE risk score. Results: among 8,869 outpatients with unknown ASCADE risk, those with a risk of 7.5% or higher as predicted by CXR-CVD risk, had a higher 10-year risk for MACE after adjustment for risk factors, adjusted hazard ratio, HR, 1.73, 95% C, 1.47 to 2.03. In the additional 2,132 outpatients with known ASCADE risk, CXR-CVD risk predicted MACE beyond the traditional ASCADE risk score, adjusted HR, 1.88, C, 1.24 to 2.85. Limitation: retrospective study design using electronic medical records. Conclusion: on the basis of a single CXR-CVD risk predicts 10-year MACE beyond the clinical standard and may help identify individuals at high risk whose ASCADE risk score cannot be calculated because of missing data. Next, we will be discussing articles from Nature Medicine. Equitable implementation of a precision digital health program for glucose management in individuals with newly diagnosed type 1 diabetes. Few young people with type 1 diabetes, T1D, meet glucose targets. Continuous glucose monitoring improves glycemia, but access is not equitable. We prospectively assess the impact of a systematic and equitable digital health team-based care program implementing tighter glucose targets, A1C less than 7%, early technology use, continuous glucose monitoring starts less than 1 month after diagnosis, and remote patient monitoring on glycemia in young people with newly diagnosed T1D enrolled in the Teamwork, Targets, Technology, and Tight Control, 4T Study 1. Primary outcome was A1C change from 4 to 12 months after diagnosis. The secondary outcome was achieving the A1C targets. The 4T Study 1 cohort, 36.8% Hispanic and 35.3% publicly insured, had a mean A1C of 6.58%, 64% with A1C less than 7% and mean time in the range, 70 to 180 mg/dL-1 of 68% at 1 year after diagnosis. Clinical implementation of the 4T Study 1 met the pre-specified primary outcome and improved glycemia without unexpected serious adverse events. The strategies in the 4T Study 1 can be used to implement systematic and equitable care for individuals with T1D and translate to care for other chronic diseases. Next, we will be discussing articles from British Medical Journal. Efficacy of psilocybin for treating symptoms of depression, systematic review and meta-analysis. Objective: to determine the efficacy of psilocybin as an antidepressant compared with placebo or non-psychoactive drugs. Design systematic review and meta-analysis. Data sources: 5 electronic databases of published literature, Cochrane Central Register of Controlled Trials, Medline, Embase, Science Citation Index, and Conference Proceedings Citation Index, and PsycInfo, and 4 databases of unpublished and international literature, clinicaltrials.gov, WHO International Clinical Trials Registry Platform, ProQuest Dissertations and Theses Global, and Psych Extra, and hand searching of reference lists, conference proceedings, and abstracts. Data synthesis and study quality information on potential treatment effect moderators was extracted, including depression type, primary or secondary, previous use of psychedelics, psilocybin dosage, type of outcome measure, clinician rated or self-reported, and personal characteristics, e.g., age, sex. Data were synthesized using a random effects meta-analysis model, and observed heterogeneity and the effect of covariates were investigated with subgroup analyses and metaregression. Hedges G was used as a measure of treatment effect size, to account for small sample effects and substantial differences between the included study sample sizes. Study quality was appraised using Cochrane's Risk of Bias 2 tool, and the quality of the aggregated evidence was evaluated using grade guidelines. Results meta-analysis on 436 participants, 228 female participants, average age 36 to 60 years, from 7 of the 9 included studies showed a significant benefit of psilocybin. Hedges G equals 1.64, 95% confidence interval, C 0.55 to 2.73, P less than 0.001, on change in depression scores compared with comparator treatment. Subgroup analyses and metaregressions indicated that having secondary depression, Hedges G equals 3.25, 95% C 0.97 to 5.53, being assessed with self-report depression scales such as the Beck Depression Inventory, 3.25, 0.97 to 5.53, and older age and previous use of psychedelics, metaregression coefficient 0.16, 95% C 0.08 to 0.24 and 4.2, 1.5 to 6.9, respectively, were correlated with greater improvements in symptoms. All studies had a low risk of bias, but the change from baseline metric was associated with high heterogeneity and a statistically significant risk of small study bias, resulting in a low certainty of evidence rating. Conclusion: treatment effects of psilocybin were significantly larger among patients with secondary depression, when self-report scales were used to measure symptoms of depression, and when participants had previously used psychedelics. Further research is thus required to delineate the influence of expectancy effects, moderating factors, and treatment delivery on the efficacy of psilocybin as an antidepressant. Next, we will be discussing articles from Lancet. Diagnosis of common health conditions among autistic adults in the UK, evidence from a matched cohort study. Background: autistic people are disproportionately likely to experience premature mortality in most mental and physical health conditions. We measured the incidence of diagnosed conditions accounting for the most disability-adjusted life years in the UK population according to the Global Burden of Disease Study: anxiety, depression, self-harm, harmful alcohol use, substance use, migraine, neck or back pain, and gynecological conditions. Methods: participants were aged 18 years or above and had an autism diagnosis recorded in the IQVIA Medical Research Database between January 1, 2000 and January 16, 2019. We included 15,675 autistic adults without intellectual disability, 6,437 autistic adults with intellectual disability, and a comparison group matched, 110 by age, sex, and primary care practice. We estimated crude incidences and incidence rate ratios, IRRs, adjusted for age and sex. Findings: autistic adults without intellectual disability experienced a higher incidence, IRR, 95% C, of self-harm, 2.07, 1.79 to 2.40, anxiety, 1.91, 1.76 to 2.06, depressive disorders, 1.79, 1.67 to 1.92, and substance use, 1.24, 1.02 to 1.51, relative to comparison participants. Incidences of harmful alcohol use, 1.01, 0.85 to 1.18, migraine, 0.99, 0.84 to 1.17, and gynecological conditions, 1.19, 0.95 to 1.49, did not differ. Neck or back pain incidence was lower, 0.88, 0.82 to 0.95. Autistic adults with intellectual disability experienced a higher incidence of self-harm, 2.08, 1.69 to 2.56. Incidences of anxiety, 1.14, 1.00 to 1.30. Gynecological conditions, 1.22, 0.93 to 1.62, and substance use, 1.08, 0.80 to 1.47, did not differ, and lower incidences were found for depressive disorders, 0.73, 0.64 to 0.83, harmful alcohol use, 0.65, 0.50 to 0.84, migraine, 0.55, 0.42 to 0.74, and neck or back pain, 0.49, 0.44 to 0.55. Interpretation. Although our findings cannot be directly compared to previous prevalence studies, they contrast with a higher frequency of mental and physical health conditions in autistic adults reported in studies that directly assessed and/or surveyed autistic people about co-occurring conditions. The present findings may suggest underdiagnosis of common conditions in autistic people, particularly those with intellectual disability. Improved detection should be a clinical and policy priority to reduce health inequalities. Next, we will be discussing articles from Journal of Clinical Oncology. Improved disease-free survival with adjuvant chemotherapy after nephroureterectomy for upper tract urothelial cancer. Final results of the POUT trial. POUT was a phase 3, randomized, open-label trial, including 261 patients with muscle-invasive or lymph node-positive, non-metastatic upper tract urothelial cancer, UTUC, randomly assigned after radical nephroureterectomy to platinum-based chemotherapy, 132, or surveillance, 129. Primary outcome analysis demonstrated that chemotherapy improved disease-free survival, DFS. At that time, the planned secondary outcome analysis of overall survival, OS, was immature. By February 2022, 50 and 67 DFS events had occurred in the chemotherapy and surveillance groups, respectively, at a median follow-up of 65 months. The 5-year DFS was 62% versus 45%, univariable hazard ratio, HR, 0.55, 95% C, 0.38 to 0.80, p equals 0.001. The restricted mean survival time, RMST, was 18 months longer, 95% C, 6 to 30, in the chemotherapy arm. There were 46 and 60 deaths in the chemotherapy and control arms, respectively. The 5-year OS was 66% versus 57%, with univariable HR, 0.68, 95% C, 0.46 to 1.00, p equals 0.049, and RMST difference 11 months, 95% C, 1 to 21. Treatment effects were consistent across chemotherapy regimens, carboplatin or cisplatin, and disease stage. Toxicities were similar to those previously reported, and there were no clinically relevant differences in quality of life between arms. In summary, although OS was not the primary outcome measure, the updated results add further support for the use of adjuvant chemotherapy in patients with UTUC, suggesting long-term benefits. Next, we will be discussing articles from Journal of Hepatology. Randomized trial of anakinra plus zinc versus prednisone for severe alcohol-associated hepatitis. Background and aims. Severe alcohol-associated hepatitis, SAH, is associated with high 90-day mortality. Glucocorticoid therapy for 28 days improves 30 but not 90-day survival. We assess the efficacy and safety of a combination of anakinra, an IL-1 antagonist, plus zinc, A plus C, compared to prednisone using the Day 7 Lille score as a stopping rule in patients with SA. Methods. In this phase IIB double-blind randomized trial in adults with SA and MELD scores of 20 to 35, participants were randomized to receive either daily anakinra 100 mg subcutaneously for 14 days plus daily zinc sulfate 220 mg orally for 90 days, or daily prednisone 40 mg orally for 30 days. Prednisone or prednisone placebo was stopped if Day 7 Lille score was greater than 0.45. All study drugs were stopped for uncontrolled infection or greater than or equal to 5-point increase in MELD score. The primary endpoint was overall survival at 90 days. Results. 73 participants were randomized to prednisone and 74 to A plus C. The trial was stopped early after a pre-specified interim analysis showed prednisone was associated with higher 90-day overall survival, 90% versus 70%, hazard ratio for death equals 0.34, 95% C 0.14 to 0.83, P equals 0.018, and transplant-free survival, 88% versus 64%, hazard ratio for transplant or death equals 0.30, 95% C 0.13 to 0.69, P equals 0.004, then A plus C. Acute kidney injury was more frequent with A plus C, 45%, than prednisone, 22%, P equals 0.001, but rates of infection were similar, 31% in A plus C versus 27% in prednisone, P equals 0.389. Conclusions. Participants with SA treated with prednisone using the Day 7 Lille score as a stopping rule had significantly higher overall and transplant-free 90-day survival and lower incidence of acute kidney injury than those treated with A plus C. Impact and implications. There is no approved treatment for severe alcohol-associated hepatitis, SAH. In this double-blind randomized trial, patients with SA treated with prednisone using the Lille stopping rule on Day 7 had higher 90-day overall and transplant-free survival and lower rates of acute kidney injury compared to patients treated with a combination of anakinra and zinc. The data support continued use of glucocorticoids for patients with SA, with treatment discontinuation for those with a Lille score greater than 0.45 on Day 7. Next, we will be discussing articles from Clinical Gastroenterology. Reduction of upper gastrointestinal bleeding risk with proton pump inhibitor therapy in Asian patients with atrial fibrillation receiving direct oral anticoagulant, a nationwide population-based cohort study. Background and aims. In patients with atrial fibrillation, AF, receiving direct oral anticoagulant, DOAC, upper gastrointestinal bleeding, UGIB, is a serious complication. There are limited data on the benefit of preventive proton pump inhibitor, PPI, used to reduce the risk of UGIB in DOAC users. Methods. We included patients with AF receiving DOAC from 2015 to 2020 based on the Korean Health Insurance Review and Assessment Database. The propensity score, PS, weighting method was used to compare patients with PPI use and those without PPI use. The primary outcome was hospitalization for UGIB. Weighted hazard ratios, HRs, and corresponding 95% confidence intervals, Cs, were evaluated using the Cox proportional hazards regression model. Results. A total of 165,624 patients were included, mean age, 72.2 plus or minus 10.8 years, mean SHA-2 VOSC score, 4.3 plus or minus 1.8, mean has bled score, 3.3 plus or minus 1.2. Among them, 99,868 and 65,756 were in the non-PPI group and PPI group, respectively. During a median follow-up of 1.5 years, the PPI group was associated with lower risks of hospitalization for UGIB and UGIB requiring red blood cell transfusion than non-PPI group, weighted HR, 0.825, 95% C, 0.761 to 0.894 and 0.798, 95% C, 0.717 to 0.887, respectively, both P less than 0.001. The benefits of PPI on the risk of hospitalization for UGIB were greater in those with older age, greater than or equal to 75 years, higher has bled score, greater than or equal to 3, prior GIB history, and concomitant use of antiplatelet agent, all P for interaction less than 0.1. Low-dose PPI was consistently associated with a lower risk of significant UGIB by 43.6 to 49.3%, P less than 0.001. Conclusions. In this large Asian cohort of patients with AF on DOAC, PPI co-therapy is beneficial for reducing the risk of hospitalization for UGIB, particularly in high-risk patients. Age, BMI, and type 2 diabetes modify the relationship between PLA3 and advanced fibrosis in children and adults with NAFLD. Background and names. MPLA3G allele is an important determinant of disease severity in non-alcoholic fatty liver disease, NAFLD. Here, we investigated the effect of age, body mass index, BMI, and type 2 diabetes mellitus, T2DM, on the relationship between MPLA3G allele and advanced fibrosis in adults and children with histologically characterized NAFLD. Methods. A total of 1,047 children and 2,057 adults were included. DNA was genotyped for RS738409 in duplicate. Primary outcome of interest was advanced fibrosis stage greater than or equal to 3. Regression analyses were performed after controlling for relevant covariates. An additive model was used to assess the effect of MPLA3G allele, CC versus CG versus GG. Results. MPLA3G allele was significantly associated with advanced fibrosis in children, odds ratio, or 1.55, 95% confidence interval, C, 1.16 to 2.09, and adults, or 1.55, 95% C, 1.16 to 1.54. Across the cohort, older age significantly increased the risk for advanced fibrosis from MPLA3CC, or 1.019, 95% C, 1.013 to 1.026, CG, or 1.024, 95% C, 1.018 to 1.030, and GG, or 1.03, 95% C, 1.023 1.037, genotypes. BMI significantly increased the relationship between MPLA3 genotypes and advanced fibrosis in children and adults. A BMI of 30 kg/m2 was the cutoff beyond which MPLA3G allele had exponential effect on the risk for advanced fibrosis in children and adults. T2DM significantly worsened the relationship between MPLA3G allele and advanced fibrosis in children and adults, interaction p less than 0.01 for both. Conclusions. Age, BMI, and T2DM modify the risk of advanced fibrosis associated with MPLA3G allele. Preventing or reversing T2DM and obesity in persons carrying MPLA3G allele may lower the risk for advanced fibrosis in NAFLD. Cardiovascular safety of ozanimod in patients with ulcerative colitis, True North and open-label extension analyses. Background and names. Evaluating cardiovascular safety of sphingosine 1-phosphate, S1P, receptor modulators is warranted due to S1P receptor expression on cardiomyocytes and vascular endothelial cells. This analysis reports the cardiovascular safety of ozanimod, an S1P receptor modulator, in patients with moderately to severely active ulcerative colitis from the Phase 3 True North, TN, and open-label extension, OLE. Methods. All patients who received ozanimod in TN, N equals 796, and all eligible TN patients who entered the OLE, N equals 823, were included. Cardiovascular-related adverse events were evaluated in patients with up to 146 weeks of ozanimod exposure, 2,219 patient years, which included 52 weeks during TN. Results. On TN Day 1, first dose ozanimod resulted in a 0.2 beats per minute mean decrease in heart rate from pretreatment to hour 6. 2 patients experienced bradycardia, which resolved without treatment modification. Mean systolic and diastolic blood pressure increases of 5.1 and 2.2 mm Hg, respectively, were observed at TN week 52. No second-degree Mobitz type 2 atrioventricular block events were reported. 1/3 degree atrioventricular block unrelated to ozanimod occurred in the OLE. Cardiac and vascular treatment emergent adverse events were infrequent, 3.8%, 31 of 823, and 8.5%, 70 of 823. No ozanimod-related cardiovascular deaths occurred. The incidences of deep vein thrombosis, 0.2%, 2 of 823, pulmonary embolism, 0.2%, 2 of 823, and ischemic stroke, 0.4%, 3 of 823, in the OLE were low. Conclusions. No new cardiovascular safety signals were identified, consistent with findings from previous ozanimod studies. There were few major adverse cardiovascular events or thromboembolic events, which were unrelated or unlikely related to ozanimod. Ozanimod has a well-tolerated cardiovascular safety profile when prescribed in accordance with the label. Next, we will be discussing articles from Clinical Infectious Diseases. Can chatbot artificial intelligence replace infectious diseases physicians in the management of bloodstream infections? A prospective cohort study. Background. The development of chatbot artificial intelligence, AI, has raised major questions about their use in healthcare. We assess the quality and safety of the management suggested by Chat Generative Pre-training Transformer 4, ChatGPT-4, in real-life practice for patients with positive blood cultures. Methods. Over a 4-week period in a tertiary care hospital, data from consecutive infectious diseases, ID, consultations for a first positive blood culture were prospectively provided to ChatGPT-4. Data were requested to propose a comprehensive management plan, suspected/confirmed diagnosis, workup, antibiotic therapy, source control, follow-up. We compared the management plan suggested by ChatGPT-4 with the plan suggested by ID consultants based on literature and guidelines. Comparisons were performed by 2 ID physicians not involved in patient management. Results. 44 cases with a first episode of positive blood culture were included. ChatGPT-4 provided detailed and well-written responses in all cases. AI's diagnoses were identical to those of the consultant in 26, 59%, cases. Suggested diagnostic workups were satisfactory, no missing important diagnostic tests, in 35, 80%, cases. Empirical antimicrobial therapies were adequate in 28, 64%, cases and harmful in 1, 2%. Source control plans were inadequate in 4, 9%, cases. Definitive antibiotic therapies were optimal in 16, 36% patients and harmful in 2, 5%. Overall, management plans were considered optimal in only 1 patient, as satisfactory in 17, 39%, and as harmful in 7, 16%. Conclusions. The use of ChatGPT-4 without consultant input remains hazardous when seeking expert medical advice in 2023, especially for severe IDs. Process trial. Effect of duloxetine premedication for postherpetic neuralgia within 72 hours of herpes zoster reactivation, a randomized controlled trial. Background. Postherpetic neuralgia, PHN, is the most common chronic complication of herpes zoster, HC, and results in severe refractory neuropathic pain. This study aimed at evaluating the efficacy of premedication with duloxetine in the prevention of PHN. Methods. The process trial is a multi-center, randomized, open-label, blinded endpoint trial used a 1-to-1 duloxetine control ratio. Adults 50 years or older with HC who presented with vesicles within 72 hours were recruited. The primary outcome was the incidence of PHN at 12 weeks. PHN was defined as any pain intensity score other than 0 on the Visual Analog Scale, VAS, at week 12 after the onset of the rash. The secondary outcomes were the number of participants with VAS greater than 0 and VAS greater than or equal to 3. The modified intention to treat, MIT, principle and per protocol, PP, principle were used for the primary outcome analysis. Results. A total of 375 participants were randomly assigned to the duloxetine group, and 375 were assigned to the control group. There was no significant difference in the incidence of PHN in the duloxetine group compared with the control group in the mid-analysis, 86, 22.9%, of 375 versus 108, 28.8%, of 375, p equals 0.067. PP analysis produced similar results. However, there were significant differences between the two groups in the number of participants with VAS greater than 0 and VAS greater than or equal to 3, p less than 0.05 for all comparisons. Conclusions. Although absolute prevention of PHN does not occur, this trial found that premedication with duloxetine can reduce pain associated with HC, and therefore can have clinically relevant benefits. Evaluation of the specificity of the 2023 Duke International Society of Cardiovascular Infectious Diseases classification for infective endocarditis. Background: the 2023 Duke ISFID, International Society of Cardiovascular Infectious Diseases, classification is a new diagnostic tool for infective endocarditis, updating the 2000 modified Duke and the 2015 European Society for Cardiology, ESCAPE, classifications. In comparison, its sensitivity is higher, however, its specificity remains to be evaluated and compared to that of the two other classifications in endocarditis suspected patients. Methods: we retrospectively collected the characteristics of patients hospitalized in Bichat University's Hospital, Paris, in 2021, who had been evaluated for clinical suspicion of endocarditis, have had at least a transthoracic echocardiography, 2 pairs of blood cultures, 3-month follow-up, and in whom endocarditis diagnosis was finally rejected. All patients were classified by 2000 modified Duke, 2015 ESCAPE, and 2023 Duke ISFID, as though the endocarditis diagnosis had not been rejected. Results: in total, 130 patients' charts were analyzed. Mean age was 62 years, 84, 64.6% were male, 39, 30.0%, had prosthetic cardiac valve or valve repair, 21, 16.2%, cardiac implanted electronic device, and 30, 23.1%, other cardiac conditions. Overall, 5, 2, and 5 patients were falsely classified as definite endocarditis with the 2000 modified Duke, 2015 ESCAPE, and 2023 Duke ISFID classifications, respectively. The corresponding specificities were 96.2%, 95% confidence interval, C 90.8%, 98.6%, 98.5%, 95% C, 93.9%, 99.7%, and 96.2%, 95% C, 90.8%, 98.6%. The rates of possible endocarditis were of 38%, 35%, and 35% in the 3 classifications, respectively. Conclusions: the 2023 Duke ISFID classification is highly specific for ruling out the diagnosis of definite infective endocarditis in patients who had been evaluated for E. Next, we will be discussing articles from Journal of Clinical Rheumatology. Chronic nonbacterial osteomyelitis associated with familial Mediterranean fever in children. Objective: chronic nonbacterial osteomyelitis, CNO, is a non-infectious autoinflammatory bone condition that frequently occurs alongside other inflammatory diseases, such as familial Mediterranean fever, FMF. We aim to determine the demographic, clinical, laboratory, and radiological characteristics of patients diagnosed with both FMF and CNO. Methods: we reviewed the medical records of pediatric patients with both CNO and FMF at 3 pediatric rheumatology centers in Turkey from December 2008 to 2022. Patients' demographics, laboratory features, imaging findings, and treatment were recorded. Results: 12 patients with FMF and CNO were included in the study. Half of them were girls. The mean ages at onset for FMF and CNO symptoms were 80 and 116 months, whereas the ages at diagnosis for FMF and CNO were 100 and 125 months, respectively. 10 patients, 83.3%, had M694V mutation on at least one allele of the Mediterranean fever, MEF, gene. The most common sites of osteitis were the long bones, 58.3%, pelvis, 50%, and clavicles, 25%. 10 patients, 83%, received nonsteroidal anti-inflammatory drugs, 8, 66%, received disease-modifying antirheumatic drugs. Biological therapy was administered to 5 patients, 41%, who did not respond to these treatments, and all patients received colchicine. Conclusion: the increased frequency of FMF in patients with CNO is of interest. Because most patients with CNO and FMF carried a homozygous or combined heterozygous M694V mutation, we speculated that the M694V mutation may play a role in the development of osteitis. Further studies are needed to elucidate the link between FMF and CNO. Comparative levels of urinary biomarkers of renal injury and inflammation among patients with diabetic nephropathy with or without hyperuricemia. Background: the association between hyperuricemia and development of progressive chronic kidney disease has received increasing attention in recent years. Recent preclinical studies have shown that non-crystalline uric acid can induce renal-specific arteriolopathy, leading to renal injury and tubulointerstitial inflammation. Methods: we conducted an open-label cross-sectional study of 25 patients with chronic kidney disease stage 3, estimated glomerular filtration rate, EGFR, 7.0 mg/dl, levels of serum uric acid. To determine the correlation between hyperuricemia on urinary protein levels and renal disease progression, we retrospectively compared urine protein and EGFR data between the two groups. Results: 11 patients with normal uric acid levels and 14 with hyperuricemia were enrolled. Urinary levels of both kidney injury molecule 1 (KIM1) and monocyte chemoattractant protein 1 (MCP1) were significantly higher in patients with hyperuricemia. Among the normuricemic white and African American (AA) subgroups, there was no difference in KIM1 or MCP1 levels, whereas KIM1 levels were significantly higher among hyperuricemic AA patients with hyperuricemia. Urinary protein was significantly higher between whites and AA patients with serum uric acid level greater than 7.0 mg/dl, as well as patients with urinary KIM1 levels greater than 1000 pg/mg/cr. A trend toward a more rapid decline in EGFR was noted among hyperuricemic AAs, however, this trend was not statistically significant. Conclusions: patients with type 2 diabetic nephropathy and persistently elevated serum uric acid levels express higher levels of both KIM1 and MCP1, reflective of ongoing renal injury and inflammation. Next, we will be discussing articles from Arthritis and Rheumatology. A mobile health application integrated in the electronic health record for rheumatoid arthritis patient-reported outcomes, a controlled interrupted time series analysis of impact on visit efficiency. Objective: patient-reported outcome, PRO, collection between visits for rheumatoid arthritis, RA, could improve visit efficiency, reducing in-person visits for patients with stable symptoms while facilitating access for those with symptoms. We examined whether a mobile health pro application integrated in the electronic health record, EHR, could reduce visit volume for those with RA. Methods: we developed an application for RA that prompted patients every other day to complete brief pro questionnaires. Results of the application were integrated into the EHR. We tested the application in a controlled interrupted time series analysis between 2020 and 2023. Rheumatologists received EHR-based messages based on pro results recommending the patient receive a visit earlier or later than scheduled. The primary outcome was monthly visit volume during the year before versus the year after initiation. Results: a total of 150 patients with RA consented and used the application. The median age was 62 years, 83% were female, 7% had fewer than 2 years of disease, and 50% were seropositive. 150 controls were well matched. Among those in the application cohort, the estimated monthly median visit volume in the year before use of the application was 31.2, 95% confidence interval, 95% C, 28.0 to 34.3. In controls, this was 30.4, 95% C, 27.3 to 33.6. In the year using the application, the estimated monthly visit volume was 36.8, 95% C, 33.4 to 40.3, compared to 38.7, 95% C, 35.2 to 42.3, in controls. The difference in the differences between the cohorts was not statistically significant, minus 2.7 visits, 95% C minus 9.3 to 4.0. No differences were noted in flare rates or visit delays. Conclusion: in this initial trial of a pro application intervention to improve visit efficiency, we found no association with reduced visit volume. Next, we will be discussing articles from Circulation. Reduced ejection fraction in elite endurance athletes, clinical and genetic overlap with dilated cardiomyopathy. Background: Exercise-induced cardiac remodeling can be profound, resulting in clinical overlap with dilated cardiomyopathy, yet the significance of reduced ejection fraction, F, in athletes is unclear. The aim is to assess the prevalence, clinical consequences, and genetic predisposition of reduced F in athletes. Methods. Young endurance athletes were recruited from elite training programs and underwent comprehensive cardiac phenotyping and genetic testing. Those with reduced F using cardiac magnetic resonance imaging, defined as left ventricular F less than 50%, or right ventricular F less than 45%, or both, were compared with athletes with normal F. A validated polygenic risk score for indexed left ventricular end systolic volume, PRS, previously associated with dilated cardiomyopathy, was assessed. Clinical events were recorded over a mean of 4.4 years. Results. Of the 281 elite endurance athletes, 22 plus or minus 8 years, 79.7% male, undergoing comprehensive assessment, 44 of 281, 15.7%, had reduced left ventricular F, N equals 12, 4.3%, right ventricular F, N equals 14, 5.0%, or both, N equals 18, 6.4%. Reduced F was associated with a higher burden of ventricular premature beats, 13.6% versus 3.8% with greater than 100 ventricular premature beats/24 hours, P equals 0.008, and lower left ventricular global longitudinal strain, 17% plus or minus 2% versus 19% plus or minus 2%, P less than 0.001. Athletes with reduced F had a higher mean PRS, 0.57 plus or minus 0.13 versus 0.51 plus or minus 0.14, P equals 0.009, with athletes in the top decile of PRS having an 11-fold increase in the likelihood of reduced F compared with those in the bottom decile, P equals 0.034. Male sex and higher PRS were the only significant predictors of reduced F in a multivariate analysis that included age and fitness. During follow-up, no athletes developed symptomatic heart failure or arrhythmias. 2 athletes died, one from trauma and one from sudden cardiac death, the latter having a reduced right ventricular F and PRS greater than 95%. Conclusions. Reduced F occurs in approximately 1 in 6 elite endurance athletes and is related to genetic predisposition in addition to exercise training. Genetic and imaging markers may help identify endurance athletes in whom scrutiny about long-term clinical outcomes may be appropriate. Next, we will be discussing articles. American College of Cardiology. Catheter ablation as first-line therapy in persistent AF study questions. What are the prevalence, patient characteristics, and clinical outcomes of patients with persistent atrial fibrillation, per AF, who underwent catheter ablation as a first or second-line strategy? Methods. This was an observational study of patients with per AF at 9 hospitals in the United States. Patients were divided into those who underwent ablation as first or second-line therapy. Patient characteristics and clinical outcomes were compared between the groups. Results. There were 2,083 patients who underwent ablation for per AF. Among those, 1,086, 52%, had ablation as a first-line treatment. Compared to patients treated with antiarrhythmic drugs, AADs, as a first-line, these patients were predominantly male, 73% versus 68%, with a lower frequency of hypertension, 64% versus 73%, and heart failure, 19% versus 31%. During a mean follow-up of slightly under 1 year, arrhythmia-free survival was similar between groups. However, patients in the second-line ablation strategy were more likely to remain on AAD therapy, 42% versus 16%. Conclusions. A first-line ablation strategy for per AF is common in the United States, particularly in men with fewer comorbidities. Perspective. The success rate of catheter ablation is higher in paroxysmal AF, PAF, than in per AF, and catheter ablation has a Class I guideline indication in patients with phanclasia in those with per AF. The authors of the present study showed that about 1/2 of patients across an assortment of medical centers, both academic and non-academic, including low and high volume, underwent an ablation for PUR-AF as first-line treatment before attempting to control the rhythm with AADs. Recent studies suggest that catheter ablation likely outperforms AADs in PUR-AF, as it does in PF. Additionally, studies have shown that early rhythm control with catheter ablation is superior to AADs in slowing the progression from PF to PUR-AF. In this study, referral for catheter ablation in PUR-AF as first-line treatment was associated with a 2/3 reduction in the need for AAD therapy after ablation. These data underscore the need for prospective and randomized data to help identify the patients with PUR-AF who may derive the maximal benefit from catheter ablation as first-line therapy. Next, we will be discussing articles from journals of the American College of Cardiology. Combined effects of clonal hematopoiesis and carotid stenosis on cardiovascular mortality. Background: the expansion of hematopoietic stem cells caused by acquired somatic mutations, clonal hematopoiesis, CH, is a novel cardiovascular risk factor. The prognostic value of CH in patients with carotid atherosclerosis remains to be evaluated. Objectives: this study assessed the prognostic significance of CH in patients with atherosclerosis as detected by ultrasound of the carotid artery. Methods: we applied deep sequencing of selected genomic regions within the genes NTO, TET2, ASXL1, and JAK2 to screen for CH in 968 prospectively collected patients with asymptomatic carotid atherosclerosis evaluated by duplex sonography. Results: we detected clonal markers at variant allele frequency greater than or equal to 2% in 133, 13.7%, of 968 patients, median age 69.2 years, with increasing prevalence at advanced age. Multivariate analyses including age and established cardiovascular risk factors revealed overall presence of CH to be significantly associated with increased risk of cardiovascular death, HR, 1.50, 95% C, 1.12 to 2.00, p equals 0.007, reflected also at the single gene level. The effect of CH was more pronounced in older patients and independent of the patient's inflammatory status as measured by high-sensitivity C-reactive protein. Simultaneous assessment of CH and degree of carotid stenosis revealed combined effects on cardiovascular mortality, depicted by a superior risk for patients with greater than 50% stenosis and concomitant CH, adjusted HR, 1.60, 95% C, 1.08 to 2.38, p equals 0.020. Conclusions: CH status in combination with the extent of carotid atherosclerosis jointly predict long-term mortality. Determination of CH can provide additional prognostic information in patients with asymptomatic carotid atherosclerosis. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Gene expression signatures predict first-year response to somapacitan treatment in children with growth hormone deficiency. Context: the pretreatment blood transcriptome predicts growth response to daily growth hormone, GH, therapy with high accuracy. Objective: investigate response prediction using pretreatment transcriptome in children with GH deficiency, GHD, treated with once-weekly somapacitan, a novel long-acting GH. Methods: REAL4 is a randomized, multinational, open-label, active-controlled parallel group phase 3 trial, comprising a 52-week main phase and an ongoing 3-year safety extension, NCT 038111535. A total of 128,200 treatment-naive prepubertal children with GHD consented to baseline blood transcriptome profiling. They were randomized 2:1 to subcutaneous somapacitan, 0.16 mg/kg/week, or daily GH, 0.034 mg/kg/day. Differential RNA-seq analysis and machine learning were used to predict therapy response. Results: 128 samples passed quality control. Children treated with somapacitan, N equals 76, or daily GH, N equals 45, were categorized based on fastest and slowest growing quartiles at week 52. Prediction of height velocity, HV, cm/year, was excellent for both treatments, out of bag, OOB, area under curve, AUC 0.98 to 0.99, validation AUC 0.83 to 0.84, as was prediction of secondary markers of growth response, HV standard deviation score, SDS 0.99 to 1.0, 0.75 to 0.78, change from baseline height SDS, delta HSDS 0.98 to 1.0, 0.61 to 0.75, and change from baseline insulin-like growth factor SDS, delta IGF-I SDS 0.96 to 1.0, 0.85 to 0.88. Genes previously identified as predictive of GH therapy response were consistently better at predicting the fastest growers in both treatments in this study, UBA AUC 0.93 to 0.97, and the slowest, 0.67 to 0.85. Conclusion. Pretreatment transcriptome predicts first-year growth response in somapacitan-treated children with GHD. A common set of genes can predict the treatment response to both once-weekly somapacitan and conventional daily GH. This approach could potentially be developed into a clinically applicable pretreatment test to improve clinical management. Stratification of atherosclerosis based on plasma metabolic states. Context. Atherosclerosis is a dominant cause of cardiovascular disease, CVD, including myocardial infarction and stroke. Objective: to investigate metabolic states that are associated with the development of atherosclerosis. Methods: cross-sectional cohort study at a university hospital in the Netherlands. A total of 302 adult subjects with a body mass index, BMI, greater than or equal to 27 kg/m2 were included. We integrated plasma metabolomics with clinical metadata to quantify the atherogenic state of each individual, providing a continuous spectrum of atherogenic states that ranges between non-atherogenic states to highly atherogenic states. Results: analysis of groups of individuals with different clinical conditions, such as metabolically healthy individuals with obesity and individuals with metabolic syndrome, confirmed the generalizability of this spectrum, revealed a wide variation of atherogenic states within each condition, and allowed identification of metabolites that are associated with the atherogenic state regardless of the particular condition, such as gamma-glutamyl glutamic acid and homovinylic acid sulfate. The analysis further highlighted metabolic pathways such as catabolism of phenylalanine and tyrosine and biosynthesis of estrogens and phenylpropanoids. Using validation cohorts, we confirmed variation in atherogenic states in healthy subjects before atherosclerosis plaques become visible, and showed that metabolites associated with the atherogenic state were also associated with future CVD. Conclusion. Our results provide a global view of atherosclerosis risk states using plasma metabolomics. Next, we will be discussing articles from Neurology. Neurodevelopmental and functional outcomes following in utero exposure to anti-seizure medication, a systematic review. Background and objectives. To undertake a systematic review of the available literature to examine the relationship between prenatal anti-seizure medication, ASM, exposure and adverse postnatal neurodevelopmental outcomes, focusing on social, emotional, behavioral, and adaptive domains of human function, and the frequency of neurodevelopmental and psychiatric disorders in ASM-exposed offspring. Methods. Electronic searches of Medline, PsycInfo, and Embase were conducted and limited to studies published between 1990 and 2023 in English. Studies were eligible if they prospectively or retrospectively reported neurodevelopmental outcomes of ASM-exposed offspring. The Newcastle-Ottawa scale was used to conduct methodologic quality assessments of included studies, and a narrative synthesis integrated the review findings. Results. 43 studies were included. Valproate has been consistently associated with a 2 to 4-fold increased risk of autism spectrum disorder, ASD, 2 to 5-fold increased risk of intellectual disability, ID, and poor adaptive functioning. Growing evidence indicates that topiramate is associated with a 2-fold increased risk of ASD and 3 to 4-fold increased risk of ID. The risks of adverse neurodevelopmental outcomes for valproate and topiramate seem to be dose-dependent. Phenobarbital has been suggested to be associated with deleterious neurodevelopmental effects, but data are limited. Levetiracetam has recently been linked with an increased risk of attention deficit hyperactivity disorder and anxiety disorders in a single study. Carbamazepine has been associated with variable neurodevelopmental outcomes. Lamotrigine seems to be safe in terms of postnatal neurodevelopment. Data for oxcarbazepine, phenytoin, and clonazepam are limited but seem to have little to no risk of adverse outcomes. Evidence for the remaining ASMs, including gabapentin, pregabalin, lacosamide, zonisamide, clobazam, perampanel, ethosuximide, or brivaracetam, is lacking. Several methodologic limitations impeded data synthesis, including heterogeneity in outcome measures and small samples of monotherapy exposures. Discussion. The findings of this review support the conclusion that valproate and topiramate used during pregnancy is associated with a significantly increased risk of neurodevelopmental effects on the fetus. Apart from lamotrigine, which seems to be free of adverse neurodevelopmental effects, data for the other ASMs are mixed or inadequate to draw definite conclusions. Further research into the neurodevelopmental effects of prenatal exposure to ASMs, including most newer agents, is much needed. Next, we will be discussing articles from CHEST. Use of quantitative CT imaging to identify bronchial thermoplasty responders. Background. Bronchial thermoplasty (BT) is a treatment for patients with poorly controlled, severe asthma. However, predictors of treatment response to BT are defined poorly. Research question. Do baseline radiographic and clinical characteristics exist that predict response to BT? Study design and methods. We conducted a longitudinal prospective cohort study of participants with severe asthma receiving BT across 8 academic medical centers. Participants received 3 separate BT treatments and were monitored at 3-month intervals for 1 year after BT. Similar to prior studies, a positive response to BT was defined as either improvement in asthma control test results of greater than or equal to 3 or asthma quality of life questionnaire of greater than or equal to 0.5. Regression analyses were used to evaluate the association between pretreatment clinical and quantitative CT scan measures with subsequent BT response. Results. From 2006 through 2017, 88 participants received BT, with 70 participants, 79.5%, identified as responders by asthma control test or asthma quality of life questionnaire criteria. Responders were less likely to undergo an asthma-related ICU admission in the prior year, 3% versus 25%, p equals 0.01. On baseline quantitative CT imaging, BT responders showed less air trapping percentage, or 0.90, 95% C, 0.82 to 0.99, p equals 0.03, a greater Jacobian determinant, or 1.49, 95% C, 1.05 to 2.11, greater SD of the Jacobian determinant, or 1.84, 95% C, 1.04 to 3.26, and greater anisotropic deformation index, or 3.06, 95% C, 1.06 to 8.86. Interpretation. To our knowledge, this is the largest study to evaluate baseline quantitative CT imaging and clinical characteristics associated with BT response. Our results show that preservation of normal lung expansion, indicated by less air trapping, a greater magnitude of isotropic expansion, and greater within lung spatial variation on quantitative CT imaging, were predictors of future BT response. Individual risk factors of PM2.5 associated with wintertime mortality in urban patients with COPD background. Air pollution contributes to premature mortality, but potential impacts differ in populations with existing disease, particularly for individuals with multiple risk factors. Although COPD increases vulnerability to air pollution, individuals with COPD and other individual risk factors are at the intersection of multiple risks, and may be especially susceptible to the effect of acute outdoor air pollution. Research question. What is the association between wintertime air pollution and mortality in patients with COPD and the modifying role of individual risk factors? Study design and methods. This study evaluated 19,243 deceased veterans with prior COPD diagnosis who had resided in 25 U.S. metropolitan regions, 2016 to 2019. Electronic health records included patient demographic characteristics, smoking status, and comorbidities such as asthma, coronary artery disease, CAD, obesity, and diabetes. Using geocoded addresses, individuals were assigned wintertime fine particulate matter smaller than 2.5 g in diameter, PM2.5, and nitrogen dioxide air pollution exposures. Associations between acute air pollution and mortality were estimated by using a time-stratified case crossover design with a conditional logistic model, and individual risk differences were assessed according to stratified analysis. Results: A 1.05, 95% C, 1.02 to 1.09. Mortality risk was estimated for each 10 g/m3 increase in daily wintertime PM2.5. Older patients and Black individuals displayed elevated risk. Obesity was a substantial air pollution-related mortality risk factor, or 1.11, 95% C, 1.01 to 1.23, and the estimated risk for individuals with obesity plus CAD or obesity plus diabetes was 16% higher. Interpretation: Wintertime PM2.5 exposure was associated with elevated mortality risk in people with COPD, but individuals with multiple comorbidities, notably obesity, had high vulnerability. Our study suggests that obesity, CAD, and diabetes are understudied modifiers of air pollution-related risks for people with existing COPD. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Ambient ultrafine particulate matter and clinical outcomes in fibrotic interstitial lung disease. Rationale: particulate matter with an aerodynamic diameter 2.5 m is associated with adverse outcomes in fibrotic interstitial lung disease, FILD, but the impact of ultrafine particulates, UFPs, aerodynamic diameter 100 nm, remains unknown. Objective: to evaluate UFP associations with clinical outcomes in FILD. Methods: we conducted a multi-center, prospective cohort study enrolling patients with FILD from the University of Pittsburgh Dorothy P. and Richard P. Simmons Center, and the Pulmonary Fibrosis Foundation Patient Registry, PFFPR. Using a national-scale UFP model, we linked exposures using 3 approaches in the Simmons cohort: residential address geocoordinates, zip code centroid geocoordinates, and zip code average, and 2 in the PFFPR for which only 5-digit zip code was available, zip code centroid and zip code average. We tested UFP associations with transplantation-free survival using multivariable Cox proportional hazards models, baseline percentage predicted FVC and DLCO using multivariable linear regressions, and decline in FVC and DLCO using linear mixed models adjusting for age, sex, smoking, race, socioeconomic status, site, particulate matter with an aerodynamic diameter 2.5, and nitrogen dioxide. Measurements and main results: annual mean outdoor UFP concentrations for 2017 were estimated for 1,416 Simmons and 1,919 PFFPR patients. Increased UFP concentration was associated with transplantation-free survival in fully adjusted Simmons residential address models, hazard ratio 1.08 per 1,000 particles/cm3, 95% confidence interval, 1.01 to 1.15, p equals 0.02, but not PFFPR models, which used less precise linkage approaches. Higher UFP exposure was associated with lower baseline FVC and more rapid FVC decline in the Simmons registry. Conclusions: increased UFP exposure was associated with transplantation-free survival and lung function in the cohort with precise residential location linkage. This work highlights the need for more robust regulatory networks to study the health effects of UFPs nationwide. Deep learning classification of usual interstitial pneumonia predicts outcomes. Rationale: computed tomography, CT, enables non-invasive diagnosis of usual interstitial pneumonia, UIP, but enhanced image analyses are needed to overcome the limitations of visual assessment. Objectives: apply multiple instance learning, MIL, to develop an explainable deep learning algorithm for prediction of UIP from CT and validate its performance in independent cohorts. Methods: we trained an MIL algorithm using a pooled dataset, N equals 2143, and tested it in 3 independent populations, data from a prior publication, N equals 127, a single institution clinical cohort, N equals 239, and a national registry of patients with pulmonary fibrosis, N equals 979. We tested UIP classification performance using receiver operating characteristic analysis, with histologic UIP as ground truth. Cox proportional hazards and linear mixed effects models were used to examine associations between MIL predictions and survival or longitudinal FVC. Measurements and main results: in 2 cohorts with biopsy data, MIL improved accuracy for histologic UIP, area under the curve, 0.77, N equals 127, and 0.79, N equals 239, compared with visual assessment, area under the curve, 0.65 and 0.71. In cohorts with survival data, MIL UIP classifications were significant for mortality, N equals 239, mortality to April 2021, unadjusted hazard ratio, 3.1, 95% confidence interval, C, 1.96 to 4.91, p less than 0.001, and N equals 979, mortality to July 2022, unadjusted hazard ratio, 3.64, 95% C, 2.66 to 4.97, p less than 0.001. Individuals classified as UIP positive by the algorithm had a significantly greater annual decline in FVC than those classified as UIP negative, minus 88 ml/year versus minus 45 ml/year, N equals 979, p less than 0.01, adjusting for extent of lung fibrosis. Conclusions: computerized assessment using MIL identifies clinically significant features of UIP on CT. Such a method could improve confidence in radiologic assessment of patients with interstitial lung disease, potentially enabling earlier and more precise diagnosis. Next we will be discussing articles is from Clinical Journal of American Society of Nephrology. Vaccine effectiveness of BNT162b2 and CoronaVac against SARS-CoV-2 Omicron BA.2 and CKD. Background: the ongoing coronavirus disease 2019, COVID-19, pandemic has posed increased risks of hospitalization and mortality in patients with underlying CKD. Current data on vaccine effectiveness of COVID-19 vaccines are limited to patients with CKD on dialysis and seroconversion in the non-dialysis population. Methods: a case control study was conducted of adults with CKD using data extracted from the Electronic Health Record database in Hong Kong. Adults with CKD and COVID-19 confirmed by PCR were included in the study. Each case was matched with up to 10 controls attending hospital authority services without a diagnosis of COVID-19 on the basis of age, sex, and an index date, within 3 calendar days. The vaccine effectiveness of BNT162b2 and CoronaVac in preventing COVID-19 infection, hospitalizations, and all-cause mortality was estimated using conditional logistic regression adjusted by patients' comorbidities and medication history during the outbreak from January to March 2022. Results: a total of 20,570 COVID-19 cases, 6,604 COVID-19 related hospitalizations, and 2,267 all-cause mortality were matched to 81,092, 62,803, and 21,348 controls, respectively. Compared with the unvaccinated group, 3 doses of BNT162b2 or CoronaVac were associated with a reduced risk of infection, BNT162b2, 64%, 95% confidence interval, C, 60 to 67, CoronaVac, 42%, 95% C, 38 to 47, hospitalization, BNT162b2, 82%, 95% C, 77 to 85, CoronaVac, 80%, 95% C, 76 to 84, and mortality, BNT162b2, 94%, 95% C, 88 to 97, CoronaVac, 93%, 95% C, 88 to 96. Vaccines were less effective in preventing infection and hospitalization in the EAT for less than 15 and 15 to 29 milliliters per minute per 1.73 meters 2 subgroups as compared with higher GFR subgroups. However, receipt of vaccine, even for one dose, was effective in preventing all-cause mortality, with estimates similar to the higher EAT for subgroups, as compared with unvaccinated. Conclusions. A dose-response relationship was observed between the number of BNT162b2 or coronavac doses and the effectiveness against COVID-19 infection and related comorbidity in the CKD population. Trust, multidimensional health literacy, and medication adherence among patients undergoing long-term hemodialysis. Background. Basic health literacy and trust in physicians can influence medication adherence in patients receiving dialysis. However, how high-order health literacy is associated with medication adherence and how trust in physicians mediates this association remain unclear. We assess the interrelationships between health literacy, trust in physicians, and medication adherence. We investigated the mediating role of trust in physicians in the relationship between health literacy and medication adherence. Methods. This multi-center cross-sectional study included Japanese adults receiving outpatient hemodialysis at 6 dialysis centers. Multidimensional health literacy was measured using the 14-item functional, communicative, and critical health literacy scale. Trust in physicians was measured using the 5-item Wake Forest Physician Trust Scale. Medication adherence was measured using the 12-item Adherence Starts with Knowledge Scale. A series of general linear models were created to analyze the associations between health literacy and adherence starts knowledge scores with and without trust in physicians. Mediation analysis was performed to determine whether trust in physicians mediated this association. Results. In total, 455 patients were analyzed. Higher functional and communicative health literacies were associated with less adherence difficulties, per 1 point higher, minus 1.79. 95% confidence interval, C, minus 2.59 to minus 0.99, and minus 2.21, 95% C, minus 3.45 to minus 0.96, respectively, whereas higher critical health literacy was associated with greater adherence difficulties, per 1 point higher, 1.69, 95% C, 0.44 to 2.94. After controlling for trust in physicians, the magnitude of the association between health literacies and medication adherence decreased. Trust in physicians partially mediated the association between functional or communicative health literacy and medication adherence, especially beliefs, and completely mediated the association between critical health literacy and medication adherence, especially behaviors. Conclusions. Functional and communicative health literacies were positively associated with medication adherence, whereas critical health literacy was negatively associated with it. Each association was mediated by trust in physicians. Next we will be discussing articles is from Kidney International Reports. Aortic dilatation in children and young people with ACT. Introduction. Aortic root dilatation is a reported cardiovascular sequela seen in children and young people, CYP, with chronic kidney disease, CKD, but has yet to be described in those with autosomal dominant polycystic kidney disease, ACT. Methods. Single-center, cross-sectional study in a dedicated ACT clinic. Echocardiograms were evaluated for the presence of dilatation, defined by a z-score greater than or equal to 2, greater than or equal to 99 th percentile, SDs from the mean, at 4 standardized locations, namely the aortic valve annulus, sinuses of Valsalva, SOV, sinotubular junction, STJ, and the ascending aorta. Measurements were compared with a control group to assess prevalence, severity, and determinants of aortic dilatation. Results. 97 children, median age, interquartile range, of 9.3, 6.1, 13.6 years were compared with 19 controls without ACT or other CKD. The prevalence of dilatation ranged from 5.2% to 17% in ACT, depending on anatomical location with no aortic dilatation identified in the control group. In multivariable regression, Aortic root dilatation was significantly associated with cyst burden at the aortic valve annulus and SOV, beta equals 0.42 and beta equals 0.39, both p less than 0.001, with age at SOV, beta equals minus 0.26, p equals 0.02, systolic blood pressure, SBP, Z-score at SOV, beta equals minus 0.20, p equals 0.04, and left ventricular mass index, LVMI, at SOV and STJ, beta equals 0.24, p equals 0.02 and beta equals 0.25, p equals 0.03, respectively, following adjustment for age, sex, male or female, body mass index, BMI, Z-score, estimated glomerular filtration rate, EGFR, SBP Z-score, and LVMI. Conclusion. Our data suggests increased prevalence of aortic root and ascending aortic dilatation in sight with ACT compared with controls. Further studies are needed to understand the pathogenesis and its contribution to the high cardiovascular morbidity in ACT. Effectiveness of molnupiravir and nirmatrelvir-ritonavir in CKD patients with COVID-19. Introduction. Even with effective vaccines, patients with CKD have a higher risk of hospitalization and death subsequent to COVID-19 infection than those without CKD. Molnupiravir and nirmatrelvir-ritonavir have been approved for emergency use, but their effectiveness for the CKD population is still unknown. This study was conducted to determine the effectiveness of these drugs in reducing mortality and severe COVID-19 in the CKD population. Methods. This was a target trial emulation study using electronic health databases in Hong Kong. Patients with CKD aged 18 years or older who were hospitalized with COVID-19 were included. The per-protocol average treatment effect among COVID-19 oral antiviral initiators, including all-cause mortality, intensive care unit, ICU, admission, and ventilatory support within 28 days, were compared to non-initiators. Results. Antivirals have been found to lower the risk of all-cause mortality, with molnupiravir at a hazard ratio, HR, of 0.85, 95% confidence interval, C, 0.77 to 0.95, and nirmatrelvir-ritonavir at an HR of 0.78, 95% C, 0.60 to 1.00. However, they do not significantly reduce the risk of ICU admission. Molnupiravir, HR, 0.88, 95% C, 0.59 to 1.30, nirmatrelvir-ritonavir, HR, 0.86, 95% C, 0.56 to 1.32, or ventilatory support, molnupiravir, HR, 1.00, 95% C, 0.76 to 1.33, nirmatrelvir-ritonavir, HR, 1.01, 95% C, 0.74 to 1.37. There was a greater risk reduction in males and those with higher Charlson Comorbidity Index, CCI. The nirmatrelvir-ritonavir trial also showed reduced risk for those who had antiviral treatment and received 3 or more vaccine doses. Conclusion. Both molnupiravir and nirmatrelvir-ritonavir reduced mortality rates for hospitalized COVID-19 patients with CKD. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.